But want to kick off the show with the latest on the COVID-19 front. As I said, Pfizer's vaccine rolling out today in the UK, but it can't come soon enough here in the US. Not only are we continuing to see cases rise, but also hospitalizations continue to rise as well as hospital staffs are really starting to be stretched to the brink there. We've been covering that for quite some time, but the death toll also closing in on that 300,000 mark since the pandemic began here. I want to start the show there with our first guest today, Dr. Amesh Adalja, a senior scholar at Johns Hopkins Center for Health Security, and he joins us now. And Dr. Adalja, appreciate you coming on here. I know you're very busy through all this, but first, just I guess I want to start on the news of the rollout happening in the UK. The signaling from the FDA seems to show that it could come in terms of that EUA here in just a couple days. Why do you think that we are waiting a little bit longer here to roll this out? And what do you make of the timeline here as it could come this week?
I don't think it makes a big difference that the UK was a couple of days ahead of us. You have to remember that they review these applications in a different way. They do what's called a rolling review. So the data kind of comes to them as the trials are going on, whereas the FDA basically has kind of a data dump prior to the emergency use authorization meetings regarding the data. It's not that the FDA is not following these trials real time. It's just that the way that the UK does this leads to more of a real-time decision. And in many ways, it's kind of poetic that the birthplace of vaccination, where Edward Jenner discovered the first smallpox vaccine or developed it in the late 1700s, is embarking now on another vaccine to battle another scourge.
In the meantime, we've got a huge surge of coronavirus cases across the country right now. We had a guest on yesterday who had some pretty dire numbers out in terms of where things are going to go from now until April, when the vaccine will be available in a more larger scale, or at least the expectation of that. What are you looking at right now in terms of the numbers and how likely it's going to, or how much worse it's likely to get?
What I look at is hospital capacity. That's what I've been looking at since the very beginning. And what we're seeing is now there are record numbers of hospitalizations, over 100,000 in this country alone. And that's not spread evenly. So, for example, there are rural hospitals, suburban hospitals that are at the brink, that are worried about capacity on a day-to-day basis, converting parts of their hospital into makeshift ICUs, worrying about staffing, all of that that we predicted would happen if we didn't take proper action during the summer months, even before that, has all come to fruition. And I think it's going to be a very dark winter, as people have said, because I don't see these cases slowing down. And I think they just, I was just working yesterday in the hospital, and it seems to me almost every patient has COVID-19, one after the other, kind of never ending. And I think that's the situation that we face in the United States, is that we're going to have hospitals worried about their capacity. A lot more people are going to die before this vaccine is put into the arms of Americans.
Yeah, and Doctor, I mean, when we look at kind of who the first are to receive those vaccinations across the pond, very similar to what we saw out of the CDC panel here, and rolling that out with the elderly population and those that are in nursing homes here. When you look at that, though, I mean, we're doing the math and just kind of trying to figure out what this is going to look like when those do come out here in the U.S. If you are starting with those vulnerable populations, how quickly do you think you'll start to see the tide turn here if you are starting with those people? And where do you see 2021, the early parts of January, as we roll the vaccine out? Where do you see things going there?
You have to remember that this vaccine is being deployed to have the maximal impact. And right now, we're talking about hospital capacity. And nursing home patients represent a significant proportion of those who are in ICUs, in the hospital, in the emergency departments, and who are dying. So I do think if you can get the nursing home population vaccinated, that will at least give hospitals room to breathe. We're not going to see a major impact on transmission by just vaccinating healthcare workers and nursing home patients. But what you will see is hospitals have the ability to care for patients. We won't be worried about capacity, and you may see deaths go down. The other part of that equation is when we want to see people get closer to herd immunity, that's going to be some time away, as you said, April, spring, summer of 2021, because this is going to be something that comes out kind of on a rolling basis based on risk groups. So I don't think we'll see an impact on transmission rates, but it will be something where we'll see the public health urgency, because of the number of deaths, because of the hospitals, start to dissipate as more vulnerable populations get access to the vaccine.
One of the more fierce debates we've seen be aired out over the last week or so has been this idea of restaurants remaining open, and certainly New York now looking at shutting down indoor dining. I'm in California, where outdoor dining has now been banned. I'm curious, based on the data that you know, how significant the spread has been outdoors. And when you look at some of the larger states like a New York or like a California that's imposing really strict restrictions here, something on the like that we've seen since the spring, is this the right move, you think? Is this going to actually stem the spread of the virus, especially the way the wave has gone this time around?
So what you really have to do when you're deploying a public health intervention is look at your case contact data and understand how in your given geographic area are people getting infected. Is it because they're going to restaurants, or is it because of private gatherings? Is it gyms, or is it other activities? And what we do know is that outdoor activities tend to be much lower risk. That's why outdoor dining is often favored over indoor dining. In many parts of the country, though, it's not indoor dining, it's not restaurants that are spreading this, because we've seen restaurants kind of go above and beyond to try and make their places safer, decreasing capacity, universal masking, a lot of hand washing, separating tables. All of that has gone a long way to making restaurants a very different experience now in December of 2020 than they were in March of 2020. So, but I think that this is kind of a low-hanging fruit, and I think it becomes difficult if you're dealing with people who are getting infected at private gatherings. The case numbers are going up, and you're a governor, you're probably going to say, I need to do something, and this is something that they can do. But I don't think you're going to see a major impact if their cases are being driven by private gatherings. You're just going to drive things underground. And I think that there is also this dichotomy that people also say, the schools are closed, but the restaurants are open. But I think both can be open in a safe manner. And the key thing is that if you're going back to lockdowns, that tells you that there's been a policy failure. We shouldn't be doing that in December of 2020. We should have had a test, trace, isolate ability. We've had months and months and months to create it. And we still in the United States in December of 2020 can't do what Taiwan and South Korea could do in March.
That's a very good point, and I'm sure there are a lot of restaurant owners out there that would be very excited to hear you say we shouldn't be putting all the blame on them. But lastly here, Doctor, I wanted to ask you about kind of some of the lingering questions as we do await the vaccine to get EUA, emergency use authorization, here in the U.S., because there are a few, and I don't want to hark on maybe some of the fears out there for Americans to get the vaccine, but what's your estimation of some of these question marks and where we're at in terms of maybe addressing transmission risks that you were just talking about, but also what's still to be learned about what this vaccine does in younger populations and the delay there in getting it out to kids under the age of 16? Are there other concerns or questions that you're surprised haven't been answered yet?
Well, I think we still have issues of understanding how people are getting infected in certain parts of the country. We still need to really parse apart pre-symptomatic versus asymptomatic spread. So people who never get symptoms at all versus those who are on the cusp of getting symptoms. Those individuals, the latter group, are clearly contagious. I think we need to parse that apart. We need better data on face coverings to understand what are the best face coverings to block this virus for the general public to use. We don't quite understand long haul symptoms. Who develops long haul symptoms? How do you predict them? How do you prevent them? How do you treat them? And when it comes to the vaccine, we also want to know, does this provide what's called sterilizing immunity? Does that make you impervious from infection, or could you still get asymptomatically infected? That wasn't studied. With children, I think we still want to understand what the risk factors are for severe disease. They tend to be spared in general, but there are some individuals who do have severe disease. We want to understand that. It seems to be that children are not big magnifiers within households of infections, and clearly the school experience, the educational component of the schools, not the extracurricular or the sports activities, don't seem to be contributing to the spread of this, which is very different than influenza.
No, I mean, as we continue to see deaths rising here, I mean, any help, even if it is marginal, not as strong as expected, perhaps, anything in that direction would be obviously very welcomed here. But appreciate you taking the time, as always. Dr. Amesh Adalja, Senior Scholar, Johns Hopkins Center for Health Security. Thanks again for joining us.